Okay, welcome everyone. Thank you very much for joining us today. I'm so pleased that you've been able to join us. My name is Amanda Porter, and I'm the Deputy Communications Officer on the CBS-SCB board. And on behalf of the board, I'm very, very pleased that you could join us today. This is the 5th episode of the Conversations in Canadian Bioethics series and the first in our 2023 series. This series is hosted by the Canadian Bioethics Society, and it has received generous support from SSHRC. So I have a few introductory slides and updates before I'm going to be passing it over to one of our supporting organizations for a brief spotlight, and then we're going to introduce our moderator and speakers for today's session. So we're very, very pleased that we have simultaneous live translation or interpretation available for this session in both English and French. So Dr. Eric Racine will be providing some preliminary comments in both English and French. And then our moderator and panelists will be speaking in English. So to hear everything in a particular language, you go to the interpretation icon at the bottom of your screen and click on the language that you'd like to hear. And if you can understand both languages, then you can just keep it at the default, which will allow you to hear everything in the original language that it's spoken. We're going to be holding a discussion period at the end of both panel presentations, and we'll be exploring the comments and questions that come in through the Q&A then. But at any time while the panelists are speaking, you can go ahead and enter your question or your comment then. You don't need to wait until the end. And if you would like to have your comment done anonymously, make sure that you use that anonymous function within Zoom. Otherwise, the panelist might repeat your name as it appears in the Q&A. We'd love to hear from you. If you have any feedback about this session, we'll take email comments. We'll welcome them at Canadian Bioethics Society at gmail.com. And if you haven't already, we are collecting feedback on your suggestions for future speakers, for future conversations in Canadian bioethics events. So Andrew is going to place those there we go. Thank you very much, Andrew. Appreciate that. So please do let us know if you have some thoughts about who you might like to hear from for our future sessions. This meeting is being recorded. So as I mentioned, do use the anonymous function within Zoom if you'd like that. And we record and post these on our website, and we'll also share a link to recordings of past events. You can find them there. Thank you. I'd like to acknowledge that I'm joining you today from Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. And I'll gratefully acknowledge the Nova Scotia Barrister Society for the content of this land acknowledgement. And I'll shorten it by repeating that because of the treaties that have been signed in Mi'kma'ki, we are all treaty people. Okay. So the Canadian Bioethics Society, or Société, canadienne Bioéthique, we're a national nonprofit organization. We're dedicated to exploring issues in bioethics in Canada. This series was started in 2022 to continue opportunities for coming together to discuss important things throughout the year and outside of our annual conference. We endeavored to get panelists from diverse disciplines and backgrounds. Please do jot down those dates that you see on the slide there for our future Conversations in Canadian Bioethics events. We'd love to have you join us. And if this is the first time you're hearing of the CBS-SCB and you'd like to continue to be part of conversations like today's, please do consider becoming a member at bioethics.ca. And we gratefully acknowledge all of our individual and supporting organizations. These membership fees allow us to continue to exist as a registered charity and nonprofit society. You can also follow us on Twitter at Bioethics Canada, fully written out. Very briefly, we have some awards coming up. I wanted to note that the deadline for nominations for our 2 awards has been extended to April 30th. Please go to bioethics.ca for more information about eligibility and details on the nomination process. We are also looking for 3 new board members. We have 3 positions opening up: fundraising officer, conference liaison officer, and president-elect. The deadline for this nomination is April 15th. So again, go to bioethics.ca for full details on that. And those elections happen in May. And finally, I'm very, very pleased to announce that registration is now open for our workshop and community forum. This is taking place online May 15th to 18th. It'll include peer-reviewed workshops, conversations in Canadian Bioethics event like today, our annual business meeting, and opportunities for interaction and networking, as well as some student-specific kinds of events. So please do mark your calendars and check out our registration link to join us. And there's our poster for that. So I'm very pleased that the supporting organization we're going to be highlighting today is the Pragmatic Health Ethics Research Unit, Unité de Recherche en Éthique Pragmatique de la Santé. Dr. Racine will be presenting in both English and French. So for those who haven't yet used the live translation or interpretation option, this is a good opportunity for you to give it a try. So I'm going to turn it over now to Dr. Racine for about 5 minutes to tell us a little bit about this wonderful supporting organization.
Eh bien, bonjour à tous et tous. Merci beaucoup de m'avoir.
Good afternoon, everyone. Thank you for inviting me to present the Pragmatic Health Ethics Research Unit. My slides will be in English, and I will be presenting the unit in French today. Next slide. So the Pragmatic Health Ethics Research Unit is a collective effort with a lot of members from different specialities, and our work is funded by donor agencies from Canada and Quebec. You know that, perhaps you already know that IRCM is the host of the first Center for Bioethics in Canada, led by David Roy from 1976 to 2008, and then I was recruited to continue on this tradition of bioethics research. We used to work first on neuroethics, and we diversified in the last few years. The unit's orientation, there are two components in the work that we do, and that I will present in the next slide. Essentially, we try to support people in specific moral issues and to use the issues and the problems as learning opportunities for all of us, human beings. So ethics is to find a solution to problems, but also to learn and become moral agents and develop as human beings in the light of comprehension, understanding, discussion, and ethical issues resolution. We have 3 pillars in our unit, which I will present really quickly. First of all, there is a research side of our work on conceptual and methodological research. What we try to do is to work on the concepts of ethics as tools. And this idea comes from pragmatism. And this is an approach that we used to tackle major concepts in bioethics, the notion of vulnerability, of autonomy, and this led us to develop more general ethics theories, such as the agent-deed consequence model of moral judgment, and also develop other approaches like the living ethics more recently, and also a new monography on deliberative wisdom that is going to be published very soon. The majority of our work is applied work in cooperation with patient partners and health professionals and decision makers. We want to use concepts and approaches as tools towards a better well-being and develop human beings. We work, for example, on awareness raising, on ethics in the area of rare diseases, for example. And we work also on discussion tool for medical aid in dying in the context of psychiatric care. As you can see, all our projects use a participatory approach with patients to make sure that ethics is a tool for everybody. Some of our work also is geared to pediatric adult healthcare transition. And we also developed a new living ethics laboratory that is working on 2 experiments currently, one on moral distress in intensive care at Hospital Montreal Rosemont, and the second one at the IRCM clinic on psychological distress with patients with complex diseases. So those are our activities. And we also have activities geared towards dialogue and awareness raising. We have a series of conferences to which you're invited. Some of the presentations are in French, others are in English. And we also publish a monthly newsletter about health ethics called Brainstorm. And you can register to our list so that we can send you the newsletter. And we also organize national and international workshops, such as last year, the International Neurological Society conference. And I would like to talk about a new project that could be interesting to you in order to improve moral deliberation methods. And we see it as an exercise in living ethics. It is a 5-year project that is funded by SSHRC, Social Sciences and Humanities Research Council of Canada. The project seeks to improve 3 aspects of moral deliberation methods. First of all, how we can understand cases, what kind of processes and methods we use. Secondly, how we can have a discussion on ethics. And thirdly, how we can discuss the results of a discussion. So this will be focused on a participatory method. We would like to recruit between 18 and 24 Canadian clinical ethicists so that we can have 3 working groups, 2 in English and 1 in French, so that we can co-understand, co-elaborate, co-experiment and co-publish on this topic. This is a very participatory project so that we can better understand and reflect on clinical ethics and also implement new practices that will be developed by the team. And if you're interested, you can certainly get in touch with me. We will be sending invitations very soon, and I can see a few people here that will be contacted. But this is an open project. So if you're interested in reflected on clinical ethics consultations and the methods we use, I think that this project will be very innovative because we will co-develop and co-publish as a team. Next slide. So if you'd like to know more about our activities, we have a website, pragmatichealthethics.ca, and we also have a Twitter account where you can see all our activities. And on the website, you'll find conference recordings as well and information about our unit. And as a conclusion, I would like to say that we're always interested in exchanging and discussing about new projects for our unit. So I'll be pleased to answer your questions if you have any. Thank you very much for this opportunity, and I wish you a great conference.
Thank you very much, Dr. Hassim. On behalf of the CBS, thank you very much for all of your organization's support over the years, and of course as well for your significant contribution to bioethics in Canada. Thank you. Okay, so it's now my great pleasure to introduce our moderator and panelists for today's session. Moderating today, we have Kim Stever. Kim is a clinical ethicist for Alberta Health Services. And in that role, she provides ethics consultation support for South Health Campus in Calgary Zone and public health across the province. She coordinates policy reviews and is co-leading a provincial working group focused on risk mitigation for quality improvement projects. Kim is also a PhD candidate in population and public health at the University of Calgary's Department of Community Health Sciences. Her research is in public health ethics, utilizing critical bioethics methodology to investigate how we operationalize health equity and social justice in public health policy and practice. And her dissertation explores the normative forces underlying public health responses to the COVID-19 pandemic and toxic drug poisoning crisis. She previously has her MA from the University of Alberta, where she looked at Canada's justice-related obligations to other nations during a global pandemic. So I'll pass it over to Kim in a moment. But before I'll introduce our panelists. So Dr. Adrian Guta is an associate professor in the School of Social Work at the University of Windsor. He holds a master's in social work, specializing in diversity and social justice, and a PhD in public health sciences with a collaborative specialization in bioethics. He's contributed mixed methods, critical social science, and community-based participatory health research for nearly 2 decades, with a focus on the health and wellness needs of people living with and affected by HIV and people who use drugs. His work has been funded by CIHR and SSHRC and the Ontario HIV Treatment Network. In 2021, he was inducted into the Royal Society of Canada's College of New Scholars, Artists and Scientists. And in 2022, he received the Canadian Association for HIV Research and Canadian Foundation for AIDS Research Joint Research Excellence Award in the social science track. So welcome, Dr. Guta. And finally, last but not least, Matthew Bonn. I'm pleased to introduce Matthew, who is the program manager with the Canadian Association of People Who Use Drugs. He's also an international board member with International Network of Health and Hepatitis in Substance Users, and a knowledge translator for the Dr. Peters Center. His freelance writing has appeared in publications including Filter, The Conversation, Katie, Doctors Nova Scotia, Policy Options, and The Coast, which is a local paper here in Nova Scotia. Matthew is also the 64th Canadian delegation to the Commission. He was on the 64th Canadian delegation to the Commission on Narcotic Drugs. He is a current drug user and a formerly incarcerated person. So welcome, Matthew. And now it's my pleasure to pass it over to Kim.
Thank you for that, Amanda. And I also want to take the opportunity to welcome everyone who's joining the conversation today, and to thank you for making the time, space, and energy to do so. I am honored to be moderating the discussion today. And I just kind of want to also pass along my appreciation to the CBS and SCB for providing a forum to discuss this issue. I am joining today from Calgary, Alberta, which is where I live, work, and play. And it is the traditional territory of the Indigenous people of Treaty 7 region, which includes the Blackfoot Confederacy, the Tsuut'ina First Nation, and Stoney Nakoda First Nations, as well as the Métis Nation of Alberta Region 3. So to provide a bit of an overview of our conversation today, I firstly just kind of want to reiterate the objective for today, which is to have a discussion focused on the ethical dimensions of the ongoing drug poisoning crisis. To acknowledge that this is a highly contentious and moralized subject for conversation that includes multiple entry points for ethical reflection, being kind of at the intersections of drug use, health, social and public policies. And like many of you joining today, I am very excited to listen and to learn from the experience of our speakers, who are going to be offering their own reflections from their own experience and perspectives as a way to start into engaging in this topic. In a moment, I am going to turn things over to Matthew and then to Adrian, who will each speak for approximately 15 to 20 minutes. And following their contributions, we'll have about 30 minutes to have a discussion. And just to reiterate that really is the goal for this session today, to have an engaging conversation where we can raise and challenge some of the evaluative dimensions or disciplinary considerations involved in the drug poisoning crisis in a constructive, productive, and respectful way. And just to underscore what Amanda has already said, participants, your ability is to use the Q&A function to share your thoughts, comments, questions at any point during the session. And your inputs from the Q&A function, I'll be watching, monitoring, and using that to be able to guide the conversation on your behalf. And so just before we get started, I wanted to offer maybe a few short reflections that might help either guide some of your reflection or thinking throughout the session. The first reflection that I have found helpful in this space is thinking about how the problem is conceptualized. More than 32,000 Canadians have died from opioid toxicity since national surveillance data reporting was initiated in 2016. And that is, one aspect to the crisis. There are multiple intersecting health and social related harms included here, and multiple lenses to view associated morbidity and mortality with these events. And I have found it helpful to reflect on what the problem is purported to be in this space, because it can often frame or constrain some of the values that are incorporated into the analysis of the problem, as well as shape the range of reasonable options that might be available to folks for thinking about how to move forward in this space. And it also helps to frame maybe who the solutions are intended to serve and who may continue to be excluded by some of the proposed options or proposals. Second, I wanted to reflect on being a little intentional about what language is being used in relation to the problem and by whom, just to kind of acknowledge that the discursive choices in this space can be strategic or convey certain ideological underpinnings, dominant disciplinary paradigms, or in some cases have been kind of co-opted or maybe sanitized from their original intentions. So thinking about how the problem is framed as potentially an epidemic, to borrow the language from infectious disease terminology, a crisis, a public health crisis, a public health emergency, might be instructive as to what the problem is purported to be. Thinking about the language around the problem of poisonings, overdose, or whether it's referred to as a drug policy death and by whom, and the language surrounding the war on drugs or the war on people who use drugs. And as a kind of underscore throughout all of this to promote respectful engagement, just kind of a reminder to use non-stigmatizing person-first language in this space. So I typically lean on the terminology of people who use drugs, being not a member of a community and not self-identifying in this space. That's what I have learned to be kind of the most respectful approach to that. And then finally, I think it might be helpful to reflect on our own positionality as members of the bioethics community, kind of where you situate yourself in relation to the problem. Maybe reflecting on the boundaries of your own professional practice, the use of applied or critical approaches in this space to engage in ethical reflection, or the power structures contributing to the problem, and as well how you engage with the moral perspectives of other people, and especially those on kind of the front lines of this crisis. So I think that's all I have to contribute for now in kind of framing up or setting the conversation. I will turn things over to Matt, who is going to provide some of his remarks. And maybe Matt, I think you have some slides to share with the group as well.
Yeah, and just before I get into the slides, I just want to apologize because, I've lost so many friends, and I just think this might have been a little bit harder than I thought, but I can make it through it.
Okay. Well, I just want to acknowledge that please just let us know whatever you need. In addition to being a really moralized space, it's a deeply personal and traumatic space to live through as well. So yeah, just kind of let us know how you're doing throughout.
Okay, and I actually almost shared the last of my slides, but here we go. So yeah, thank you for the lovely introduction, and my name is Matthew Bonn. I use the pronouns he, him. I am somebody who has used drugs for the majority of my life. Drugs saved my life, and very recently I've been very suicidal over not being able to be on safe supply, because my mom doesn't want me using drugs in the house, and safe supply is the only thing I think will save my life. And yeah, it's been tough lately, but I show up, I do my job, and I think it's bizarre that like we want people who are experiencing homelessness and poverty, they get safe supply, but people who are working and working in society and have their license and can be productive are the ones that get turned away. And yeah, so I work for the Canadian Association of People Who Use Drugs, and you guys may recognize some of these people. Drugs don't just impact the poor, they impact everybody. No one's immune to a drug overdose. Youth, teenagers, parents, women, everybody, and I think everybody enjoys doing drugs safely, right? And that's how we have to start to look at it. We have to provide safe drugs. So we're talking about bioethics today, which I'm certainly not an expert in, so please don't judge me. But I want to talk about a little bit about community-based ethics as well. So I'd like to begin by acknowledging that where I work and where this presentation was created was in Mi'kmaq, the ancestral unceded territory of the Mi'kmaq people. This territory is created, is covered by the treaties of peace and friendship, which Mi'kmaq and the Massey for people first signed with the British Crown in 1725. Oh, a couple other affiliations I have besides Kaput. I'm on the board of the International Network of Health and Hepatitis and Substance Users, and a knowledge translator for the Dr. Peter Center. So the presentation format, I want to talk about the context of the drug supply in real time. And these are all drugs that I've bought, usually on the dark web. Very easy, very safe. I've never been caught by the police. I think it's actually probably the way to go. If we want to look at, providing safe drugs to people, you can have quality, like people can leave remarks, and it's like an Amazon for drugs. Half measure responses to the other drug crisis, and the other drug crisis is the overdose crisis, because we look at COVID and all the money that went into that, and we get peanuts, literally peanuts to deal with the overdose crisis. And I like using the word overdose because I find poisoning puts it on the drug seller, and a lot of times people just buy drugs for people and they pool their money together. They get a better price, and that person can be charged with manslaughter or murder because they're trying to keep someone safe. The overview of Canadian accidental overdose deaths, and then ethical based responses to the crisis. So this is what the current drug supply looks like, and this is all in Halifax. Some of it, a lot, I would say, I would say, I don't know, half and half are from on the dark web, and half are from online. And as we know, all these Xanax, and Atlantic Canada is very well known for Xanax and benzodiazepines. Actually, when I was like 16, I was in an article for being one of the top guys for using benzos. And this is cocaine on the left. This is carfentanil, xylazine, which is causing like a lot of harm and damage. Some more fentanyl, and then these candies really concern me because of course we don't want youth or kids using candies, but what someone did was dip sweet tarts into etylazine, and that's because there's no quality control measure. There's no one looking over these. It's all about profit for most people. Now, I'm not saying that about everybody, but like there's some people out there that just don't get the seriousness of it. So these are some of the ethical based responses to the crisis right now. And really it's overdose prevention sites. There are some safe supply sites, but no one has ever died in one of these sites. And this one's in the Dr. Peter Center. This one's in these two are in Sister Space. And this is what drug culture looks like. It doesn't look like steel booths with mirrors. You don't go to a bar and are forced to drink by yourself at a steel booth, right? And people who use drugs shouldn't have to do that either, right? And I think if we really want to talk about regulation of drugs, we need to talk about what does drug use look like in your typical settings, right? And this should be done with drug users, and it should be manufactured with drug users, right? Like, and it solidifies a role for us in the field, right? This is our field, you know, like people who use drugs are the experts. We have been doing this for years, and now the government wants to take it over and start paying people a lot of money that have no idea what they're talking about. And then they consult us and just they consult us for tokenism, and they don't listen to a word we say. So these are just some of the, overdose deaths in Canada, right? So this is from 2016. So these are per 100,000 people. As you can tell, BC is, 805 people and higher. Ontario's actually got more deaths, but not more per ratio. But it's only getting worse, and Health Canada actually has some modeling, and I should have put the slide in, I just couldn't find it. And but the slides show if fentanyl stays the same, and say supply stays the same or increases, or overdose prevention sites increases, like essentially it says reflect. You know what I mean? Like some overdose, there may be some reduction, but this is just all mathematical model, and that we really can't rely on. So this is the safe supply concept document that Kaput has created, and if you look in any academic papers on safe supply, you will see this paper cited. Like, we created the framework for safe supply to be implemented and invented. And I'm probably over time, so I'm hurrying up. This is a great getyourdrugstested.com. It's a great service. It's only in BC, but you can email or you can send a letter with a little sample, and you give them your address, and within about a week you get your results. And we're looking at ways at doing this in Nova Scotia, but really every province should have one. And when people know what they are using, when they know the quality, the quantity, they don't overdose. They don't, not to say that there hasn't been, but it's not to the level when people don't know what they're using. And then this is my community-based research. My research. This is I didn't do this. This is a manifesto for the ethical research in the downtown east side, and this is what we expect from researchers who want to work with us. We want to get to know each other. We don't just want people coming in and we're going to do this, we're going to do that. We need an ethical review. Whose ethics? You know what I mean? Like, we're not just talking about university ethics or, the Canadian Bioethics Society. We're talking about community-based ethics, right? Because you guys want to come and research us, but we want to know why. We want to go through the ethics with you. I'm a firm believer that every academic institution should hire someone from the community to sit on the ethics board. And I think that, you know, would stop a lot of issues. And doing the research, power and peers. I'm not a big fan of the word peers, but you know, like we should actually be doing the research. We're very smart people. Like people who use drugs are resilient, we're intelligent, we're survivalists. And I think, you know, we need to give people chances, right? And you know, there are some great researchers out there that do that, but we need more of those. And then we have to bring it back to the community, and knowledge translation is huge. People don't just want to come in and do all the research and then never hear from people again. And I always end, you know, I would never just end or open a slide with all celebrities. These are people that I've lost over the last 10 years, and these are just some of them. And you know, that's why I was a little bit emotional at first and still am. And you know, I hope we can all have a quick moment of silence, or we could do that at the end maybe. Thank you.
Thanks, Matt, for that. I really appreciated the kind of correlation, just the unpacking of like what it is that we're trying to talk about, and when we're talking about safe supply, and kind of ways that that could look like, and correlating that with maybe other examples of safe or regulated supply that exist out there that we're all likely familiar with, like bars in relation to the consumption of alcohol.
And actually we're trying to change the term to regulated supply, because that's
Regulated
essentially
supply.
what it is, because no drug is exactly safe.
Mm-hmm.
But if you have a regulated supply and you know the quality, you know the quantity, people know how to dose.
Yeah, so it's kind of that taking more of an approach that allows for better informed choices, or enabling more informed choices about personal drug use in ways that maybe aren't as available to folks at present.
100%. And I think, you know, there could be a great SUAP project that you know, help people with knowledge translation around that, you know what I mean?
Mm-hmm. Mm-hmm. And I really appreciate that you brought up not only knowledge translation, but that engagement piece of you know, partnership with people who have lived experience in the area, and not necessarily in
Nah.
a way that relegates them to a status of peer, but like equal partnership. So I think that's really a topic for discussion that I'd like to come back to in the kind of discussion portion of our talk today. But just to flag that, yeah, I think that these are all really important ethics-based questions to bring up, is what respectful engagement looks like, promotion of individual autonomy, but just liberty and freedom of choice. And, you know, I think also in that is the acknowledgement that this one isn't a problem confined to, you know, a singular demographic of the population. Like anybody who is exposed to an unregulated supply is at risk. And so kind of taking a look at some of the structural implications that necessarily would bring up in this space, of how people kind of engage in risk assessment, or their ability to do so based on how they fit in,
you know,
especially youth.
Yeah, because that's when people start to experiment with drugs, right?
Mm-hmm.
I
Yeah.
mean, it needs to be taught in class, right? Like,
yeah, which I mean, that kind of also leads into, I think, your point of the status quo of where we're at right now, on the basis of some of that epidemiological modeling that you were referring to, is really insufficient at curtailing kind of the scale and the level of the devastation, trauma, and harm that we're seeing right now.
thank you, and sorry, Adrian, I meant to give a shout out to our scope and review on bioethics, and I just felt like I was going over time and I was a little emotional, so.
Yeah, no, that's fair, but yeah, maybe I'll ask about the scoping review in a second. But so I'll turn things over to you, Adrian, for now. I know you also have some slides to queue up here.
I will do that. Of course, we tested all of this in advance, and now I don't know what
It's
I'm
always
doing.
the case when it's game time. It's the challenges. Do you see the share screen option at the bottom for you?
And what do you see?
We are seeing your desktop.
You have to
Okay.
pull up your power. There you go.
There.
Okay.
That looks perfect.
Okay, great. And then you're just seeing the main slide, not my notes, right?
Correct.
Okay, so good afternoon, and thank you for inviting me to participate in this very important discussion. I will just warn everybody, I've been having some tech issues and I feel like I'm overdue for a random computer crash. So I hope that that doesn't happen. If I do disappear, I will be right back. I do want to, as others have done, acknowledge the community that I live and work in, which is the traditional territory of the Three Fires Confederacy of the First Nations, which include the Ojibwa, the Ottawa, and the Potawatomi. And also acknowledging that in the work I do, much of which is focused on issues around HIV and substance use, that Indigenous peoples across what is now Canada continue to be disproportionately impacted by these issues. Windsor does not have many harm reduction options that are available elsewhere across the province, even just further up the 401, let alone across the country. Just in terms of a bit of an agenda, I'm just going to tell you a bit about myself, the work that I do, that I've been doing for almost 2 decades now. I'm going to time myself here, and about a decade around substance use and harm reduction specifically. And I'd like to talk to you about 2 areas that I think are very important in this larger conversation. So one being substance use and harm reduction, substance use and harm reduction in hospitals. I think much of the discussion is focused on community sort of interventions, which is very, very important. But I think hospitals do have an important role. And then picking up on some things that Matt mentioned in terms of safer supply. which is also very important. And then some issues that I don't know if we discuss enough in terms of the surveillance of people who use drugs as part of this, and maybe giving a bit of a nod to kind of trying to think across ethical frameworks. And I don't have great answers for this and how to do this. This is just something that I'm interested in and would love to chat about this if others are interested. And if not, that's fine too. So just a bit about myself. I have training in social work. I'm a registered social worker in Ontario. The fact that I'm a social worker might also explain why I feel the need to kind of locate myself at the beginning of this presentation. And then I have a PhD in public health sciences with a collaborative in bioethics. And so there's a little part of me that's sort of interested in all of these issues and occasionally how they come together. And I've done research about sexual health. Matt previously, and I should say I've had the pleasure of working with Matt and Kapud in the past. Matt mentioning youth. There's of course, a lot of parallels between how we treat sexual health, adolescent sexual health, and concern about having much needed conversations about sexual health and also around substance use. And those parallels have been with us for decades. I, perhaps like others on the call, I am somebody who grew up in the 80s. Just say no to, to sex for young people, just say no to drugs for young people, didn't really work out. And we have generations of people who don't know how to have conversations about this, including people who grew up to be healthcare providers. For about 20 years, I've been doing work in the HIV sector. So for folks who are at risk of HIV and for folks who are living with HIV. And within that, I've had kind of a long-term focus on sort of what in the US is called high impact prevention, and then sort of like treatment as prevention in Canada. And so kind of interventions that bring public health and clinical care together. So for example, promoting treatment access to improve clinical outcomes in the form of reduced viral load and public health outcomes in terms of reduced transmission. And then all of these technologies and interventions that came with that, like viral load monitoring and mapping and phylogenetic surveillance, and kind of thinking about what this means in the context of ongoing criminalization of HIV non-disclosure in both Canada and the US. And within that, I started to see that people who use drugs were kind of being marked for sort of additional intervention. Coming up first is, oh, well, they won't be able to manage medication. And so we need a lot more surveillance, and we need to be thinking about things like long-acting injectables and stuff like that. And so these are things that I've been thinking about for a long time. And within some of these programs, I just found it very interesting that we see kind of public health stakeholders, we see clinical care, and we also see university-based researchers. And sometimes it's not clear, and Matt used this language earlier, sort of whose ethics are being considered here. And so sometimes it's like we're using the logic of public health ethics, other times clinical ethics, other times research ethics, and then often not the ethics of those who are most affected. And there might be some consultation, but whether or not it's meaningful isn't always clear. And my interest in HIV, recognizing that a lot of people who are living with HIV use substances for a range of reasons and find themselves perhaps more likely to need hospital-based care, kind of also led to another kind of program of research, which I'll talk about. And I used kind of critical and sort of post like postmodern, post-structural theory, which I appreciate is not necessarily the bread and butter of bioethics. So like a Foucauldian bioethics that kind of asks us to think about how morality and ethics emerge within a particular social kind of milieu, and how we kind of govern, how we are governed, govern ourselves and others through kind of the ethics of the time. And behind me, if you can see the art that a colleague gave me is a giant Foucault head being carried around. But so I found these theories very helpful. And I do a lot of community-based and participatory research. I draw heavily on the knowledge of people living with HIV, people who use drugs, this very early document, Nothing About Us Without Us, greater meaningful involvement of people who use illegal drugs, a public health, ethical, and human rights imperative. Some more recent work partnered with CUD and the Canadian Drug Policy Coalition. So if you ask folks who are most affected, they will gladly, in my experience, tell you how to improve your care, your research, whatever's up for discussion. And I've written a bit about like sort of bioethics, public health ethics, and research ethics. What I'm going to kind of do today is just a very, very quick snapshot of some research projects. What I'm presenting right now is all published. If you're interested, please have a look. But so this isn't like a formal kind of research presentation. I just wanted to highlight some work with my colleague at the Dalalana School of Public Health, Carol Strike, and that we did with Casey House Hospital. And this was about a 10-year program of research, multiple projects that aren't necessarily discussed here, but that you can find by Googling my name. But I just want to highlight this one or two projects. So we interviewed 50 participants across 2 cities. It was Toronto and Ottawa. And we talked to 26 healthcare providers, physicians, nurses, a few social workers in there as well. We heard a lot about stigma, how stigma impacts care, and I hope you can hear me. I'm getting like an internet warning.
You cut out for a second, but we can hear you now.
Okay, sorry about that.
It's okay.
So how stigma impacts care and sort of kind of cyclical hospital admissions and missed opportunities. And I just want to highlight a conversation I had with a gentleman back then. So this was pre-2016. We were not necessarily using the language of the overdose crisis or drug poisoning crisis yet. We started a lot of the recording in 2016. But this work started in about 2011. I think these interviews were done in 2014. And there's a gentleman who I spoke to who shared a story about he overdosed on fentanyl. He was revived in the hospital and did not get great care. So nobody really explained what was happening to him. There was no support in place. And basically he was ignored until he just kind of got up and left and then proceeded to use again, which then resulted in him being readmitted and under much worse conditions. So he ended up in ICU for an extended period of time. And I remember, through that conversation with him, right? Just like all of the missed opportunities that were there. And we heard about a spectrum of approaches, right? From very punitive, if there's substance use in hospital, like, people are kicked out, right? Security is involved, sometimes even the police, psychiatric holds. right? Some really awful, stigmatizing, I don't even want to call it care, but all the way to very patient-centered kind of approaches, asking folks like, what do you need to support your ability to stay here? And that a subset of providers talked about offering opioids like on site. So can you tell me what you use in the community? What kind of doses? Okay, there are opioids at hospitals. They're readily available, and sort of working with folks to prevent them going into withdrawal, and that small act like improved their care and it improved the therapeutic sort of like relationship, all of these things. Hearing from physicians talking about the importance of, look, if you're concerned that somebody might inject into a PICC line, have a conversation with them. You can say, I would prefer that you not do this. However, if you're going to, this is how you can do it more safely. And so that was happening. But those same providers were very conflicted about these practices, did not discuss them with their colleagues. They felt that they would be penalized, and so really kept a lot of that to themselves. And I wanted to share this because I presented about this work at a bioethics forum. And I said, hey, look, the way this is being dealt with by some of our colleagues in the healthcare system is that they are giving people what they need to be well during a hospital admission. And at the time, it just, it felt like a lead balloon, right? Like the idea of giving people who use drugs, giving them drugs to like regulated drugs to support their health, just was a no-go. And I think we've made a lot of progress.
Are you going in the health Canada meeting right now?
In a half hour.
What time's it? Oh, we're gonna be late. I'm gonna be late too.
So you can see that like Casey House now, went from having little harm reduction kits that like we evaluated that on site in like the nursing station to now having a supervised consumption site. So that's fantastic. We're seeing that progress. And I just wanted to highlight, I'm just conscious of the time, some work on safer supply. I just want to say I fully respect and acknowledge the safe supply concept document that Guta has produced that Matt showed previously. I think the model that I've been looking at sort of is more of like the Health Canada sort of safer supplying, right? When you get into kind of the risk mitigation kind of logics and frameworks, we go from safe to safer. But we interviewed 79 participants across 4 programs, again, 27 healthcare providers and 52 safer supply clients. And this is part of a larger program of research, OHTN, SUAP, and CIHR funded. And I did want to share a few quotes with you. So just over and over again, hearing from clients, this saved my life. It saved my life, and just hearing that over and over and over again. And this idea of giving people what they want, what's actually useful to them in terms of their immediate needs, so opens up so many opportunities. And what you can achieve when you have non-judgmental, non-stigmatizing, non-punitive care, but also the moral distress for providers, not some of the stuff that we heard about previously, might hear about in the literature. Oh, am I sort of quote enabling somebody? But in this case, the complexities around triaging in a crisis, right, where at any moment somebody could lose their life, limited drug options, and limited resources. So in terms of the limited drug options, fentanyl is the substance of choice for many people. That's the reality of what's available. So we, in Ontario at least, we're not offering fentanyl as an option for safer supply yet. And of course, limited resources that programs are having to turn folks away. So I just want to highlight a few quotes. This is from a client, a woman in Toronto, who talks about having been discriminated across like every other healthcare setting, every other interaction, but that within the context of safe supply, you know, that's not happening. Another woman from Toronto, the program has saved their life, their husband's life. And again, just, you know, I wouldn't be alive without this, just was a consistent theme. And hearing about what's happening to folks who've been disengaged from healthcare, sometimes for years, sometimes for decades, who by virtue of having the safer supply, of having you know, a welcoming space where their substance use isn't like the focus of everything, they're getting other things taken care of. I got my eyes done, my dental's being done. And, you know, they said that they've realized now they have kind of problems from head to toe, but, you know, they're working through them. And just folks talking about having what to them is kind of a normal life where things aren't, their identity isn't sort of run around by their substance use needs, and that they can pursue other interests, folks reconnecting with family, friends, community, just very powerful. And I guess I have my social worker hat on here. You know, hearing people talk about now being able to be in their kids' lives, right? If they had lost custody. And from the provider side, you know, seeing this as an engagement tool, giving patients something that's actually useful to them and that brings them back into healthcare. This is from an MD. It's a very powerful quote from a nurse practitioner. I wouldn't do this if I didn't believe deeply that this is the answer to the opioid epidemic and all of the harm and tragedy associated with that. And I know that for a fact because my patients tell me that every day, and that it's life-changing and life-saving. And there's nothing else that we do in primary care that consistently gets that response. But again, recognizing that there's so many people who need this, who are in danger. Some providers described it as a sea of need when they started to take safer supply clients, and how awful it is to have to turn them away. And kind of talking about the moral consequences of this work. And some of the nurse practitioners and the physicians were very committed to this, but they felt conflicted around, again, having to turn folks away, but also wanted this to be community-led. They didn't necessarily want medicalized safer supply. They wanted kind of like, as the Kaput document outlines, a regulated supply, but that's managed by community, so drug buyers, clubs, that kind of stuff, and that they come in and you know, and do the clinical piece without, as this person says, you know, sort of being handcuffed by the logics of like clinical practice. And I'll just be very brief here. I think all of this is fantastic in terms of the new opportunities we have around. I mean, like the range of options for folks, from abstinence to kind of mainstream addictions medicine to, you know, safer supply. But I think there are some possible trade-offs here, right? We're seeing a lot more clinical and public health surveillance, even police partnerships, which we're told are a good thing, but I don't think necessarily reflect the desires of people who use drugs. And I remember when this article, this filter article came out, this really stayed with me. So the fentanyl users dispiriting search for safer supply in Toronto. And they talk about having called every single program, about, you know, disclosing their substance use, about being on multiple wait lists. And I was really thinking at the time about all of the folks who came forward, who had kept their use hidden and were sort of on the books now, that all of this is charted, right? You're a safe supply patient, and that we're not really talking about that. We're not talking about how these clinical records are being used. We're not talking about how overdose statistics are being used, and using that like in HIV, where you're doing mapping and showing where overdoses happen in a city, and it's sort of seen as innately helpful somehow for public health purposes, but there's of course the risk of stigma. And this is just a piece I led by a fantastic PhD student at York named Liam Michaud, and my colleague Emily van der Meulen at Metropolitan Toronto University, where we talk about some of this. And again, just issues around consent, and just some of the concerns about how some of this data might be used if a government changes, if support for safer supply disappears. And I just want to end with there's a lot happening, and this is very much a wicked problem and may require sort of new ways of thinking about ethics. And again, I noticed that a lot of the innovation here is kind of embedded in complex interventions and implementation science or evidence-making interventions, and something like safer supply is kind of being developed and implemented and tested kind of all at the same time. And I've been, thinking about sort of what we can use from bioethics, clinical ethics, public health ethics, and research ethics, maybe in a different way to kind of support our thinking about some of these issues. And again, I don't have a great answer to this, but I'm noticing more and more in things that I'm reading or things that I'm reviewing. There's a lot of cross-pollination and overlap, and sort of folks asking, oh, well, what if we use this concept from here and from here? And anyway, I would love to talk about that with all of you if there's any interest. And I will stop there.
Thanks, Adrian. I think there would be a lot of interest in that. And before I provide a comment, I just want to acknowledge, Matt, I can see that your hand is up, and I don't know if there was something specifically that you wanted to comment on within Adrian's presentation.
I just wanted to thank Adrian for his presentation and all the work he has done with Kaput, and I did have a question, but I lost it about halfway through, so
Sorry.
I hope I'll remember it.
That's okay. So I just want to remind participants that the Q&A function is available to help navigate the remaining time that we have left. Thank you both for kind of walking us through some of your work and experience and involvement in this. There are a lot of commonalities, I think, between the perspectives that both of you offered. But I want to maybe ask about the distinction a little bit more clearly about safe supply and safer supply to maybe kick us started, because I don't, just for my own framing, it sounds like one is maybe more of a medicalized prescribed approach, and maybe the other is a little bit broader to get around Adrian, what you had just described as the sea of needs, and maybe the bottlenecking that we're experiencing in some of our clinics for things like access to opioid agonist therapies right now. And I don't know if I'm reading between the lines correctly on that one, but just kind of thinking about maybe who's included in that approach, and also maybe who's excluded, if there is a difference between those models.
I'll defer to Matt.
I can go quickly, and I think Jeff Kirby is on this call. And when we were opening the overdose prevention site in Halifax, he was extremely helpful at seeing what the ethics were and helping us out, like, can we do this? Is it ethical? What are some of the pieces that we need to think about? And so yeah, I just wanted to give a shout out to him. Sorry, I didn't mean to cut you off, Adrian.
Oh, are you done, Matt? Oh, okay.
Yeah, it's kind of more of a, I'm not an ethics expert, but I actually got my first ethics application approved for the UBC to do some drug smoking research, so I'm pretty proud of that.
So if I look at the CAPUD definition, so safe supply is a legal and regulated supply of drugs with mind-body altering properties that traditionally have been accessible only through the illicit market. And sort of my understanding of that was, really opening up access broadly, right? Rejecting kind of the historical war on drugs, the war on people who use drugs. And then there's like when Health Canada came in, and then so they switched from safe to like safer supply, and it was very much focused on a physician. So they kind of shifted from that this would give non-addictions addictions medicine folks some leeway to start prescribing. And so you go from again people who use drugs calling for a much more meaningful response to the overdose and drug poisoning crisis that would let them take this into their own hands, into something that's much more medicalized. But that's just my sort of reading, but I'm happy to to hear if others have a different reading of that. But Kim, does that answer your?
Yeah, I wanted to, clearly parse out that distinction and kind of what you saw as being the two approaches there, and wondered if the broadening of the medical model of a safe supply was on the basis of diagnosed substance use disorder or opioid use disorder, and then so might not be accessible to people who don't identify or don't meet that criteria.
Yeah, and I would completely agree, and I think I always say you don't go to your doctor for a bottle of wine, so why would you go to your doctor for a line of cocaine, right? And I think the more we can move away from having this medicalized model and having it in the hands of drug users through compassion clubs and through quality control accountability measures such as testing, labeling, telling people exactly what's in the package, like that's what the government does anyways, you know what I mean? And if you can do it in a way where no one makes profit, then what's that, where's the argument to be made?
Mm-hmm. Thank you for that. And I think that leads me to another thread that appeared consistent to me throughout both of your presentations was that, both of you have a fairly extensive, research background, and both highlighted the importance of community participatory approaches, approaches that meaningfully engage with people who have experience in this space, which is, in line with some past conversations we've had with the CBS, particularly I'm thinking about one in relation to racism and the perpetuation of systemic injustice and exclusion of certain perspectives at the kind of decision-making table or contribution to evidence and all of those types of things. So I'm wondering if there is
Excuse me, I have a meeting from 3 to 5, which is pretty important.
Thank you, Matt. Yes.
sorry I had to duck off a little bit early, but it was a really great conversation, and I hope we can do another one of these again.
Thank you, Matt. Thank you for your contributions and for joining us.
Thank you.
Thanks, Matt.
So potentially, Adrian, I'll focus that to you. What does meaningful engagement in this space mean for you?
Oh, that's a big one.
It is.
So I've written more about that sort of in relation to HIV, and there it's there's an infrastructure kind of around that. There's policies. So the greater involvement of like originally it was GPA, the greater involvement of people with AIDS, and this is something at the UN level that countries signed on to, including Canada. And then if you look within UN documents, it's well articulated in terms of what that looks like. Critiques have been offered about that. So when it's so well articulated, it then frames like this is what community, is allowed to kind of talk about. So, but you see that basically at the international level, and then there have been efforts to kind of evaluate what that looks like at the country level. And so I guess my point is it can be like built in, or it can be sort of more informal. And I think Matt mentioned this. So most of my work is community based, right? Sitting down with a partner, a clinical partner, an advocacy partner, and kind of working through how do you want to do this? What's important to you? How do you want to do it? What are, I guess I'm trying to not say boundaries, but that is what it's about. And fortunately, funders are allowing that, because that has costs associated, right, in terms of like time and stuff. And of course, so much of this is influenced by research done with Indigenous peoples in Canada, and the expectation for consultation and dialogue, and that's spread out beyond. But the Canadian Institutes of Health Research has their CBI, STPBI grants, their Catalyst grants, where you can apply for a grant just to facilitate you coming together and figuring out what the issues are and how you want to work together. So it's mostly how I've done that, and then making sure to budget for advisory groups, but that doesn't necessarily constitute meaningful engagement, right? That could be just folks coming out, you show them, hey, these are the questions we're going to ask, what do you think? And that's it. Or you can also ask folks how they want to run those sessions, and integrating other activities, things that they want to learn or take away from that process has also been very rewarding. You can have a bit of fun and some food, and also talk research as well. And food just goes a long way with, I think, everybody.
With everybody, for sure. Yeah.
I don't know if that answered your question.
Absolutely. Yeah. Like, I think there is this kind of, as you said, there's a bit of a structural overarching piece about time and funding and expectations around that. But even under the structures that we have available now, there's kind of your own relational building and ways that you comport with people to include them right from the get-go. And thank you for kind of acknowledging, OCAP models and other sources that have really championed that work so far. I'm wondering, you mentioned that you had been thinking about ways of integrating different approaches across bioethics, public health ethics, research ethics. And so in looking at that space, are there questions that, members of the Canadian Bioethics Society in Canada should be having, paying closer attention to, or leading?
That is a good question. Yes, the answer is yes. Yeah, I don't know. I sort of, a lot of this kind of lives in my head, and then I haven't had an opportunity to kind of talk about it. What do you think of that? And does it make sense? Sort of this observation that I feel like these worlds, like clinical care, public health, research are, and I know that they've always been intertwined, but I feel, like again, like something like safer supply is a good example where like the boundaries aren't clear, and different agendas are converging, and that's not necessarily a bad thing, but I just don't know if the old rules still apply.
Yeah, I don't know what if there are old rules, but I mean, I think you picked up on the fact that some of the work in this space across disciplines can be very siloed, and we don't always do a great job of paying attention to multidisciplinary perspectives and the advancements made in other disciplines, and looking for ways to cross-pollinate or collaborate and kind of coalesce efforts on a particular goal. There are, I think, a lot of different intersection points for working on this space. If I could offer, I mean, there's work in kind of the institutions, be they kind of academics and university and doing scholarship, but there's also kind of the work in healthcare settings, as you kind of highlighted, that there are ways that people who work in healthcare settings can utilize resources to kind of reduce structural barriers or reduce risk, maybe taking on more of a person-centered approach, and maybe combating some of that legacy of stigma that we have around autonomy and empowerment over people's own choices and their own bodies. And I mean, I think even the opportunity to have a conversation like this at a national forum and to kind of prioritize this as an area of discussion is meaningful engagement, or at least a step towards meaningful engagement, and in hoping to further the reflection there. But I think we have 1 minute left, so I'm not sure if Amanda needs to step in and cut us off, but just to kind of acknowledge that there is also this political space, and public policy making is, a fundamentally ethical enterprise. And of course, there have been some disparities in the integration of evidence and perspectives and kind of the ethical counterparts that go alongside them into the public policy debates around this area. So yeah, I see Amanda's come on. We're at time, likely.
Amanda, do you have an answer to all of these questions?
No,
but it'd be great to have some more conversation another time, certainly. And I apologize to those of you who submitted questions, the Q&A that we didn't get to yet. But if it's okay with you, Adrian, I wouldn't mind forwarding those on to you and Matt, to see if you might want to continue the conversation electronically, because there's some interesting comments and questions in there. So thank you very much, Kim, Adrian, and Matt, who's not here anymore, and Eric, for your contributions to today's session. It was excellent. I hope you will consider joining us for the workshop and community forum in May, that you'll consider nominating a colleague for one of our awards, and that you'll consider running for our board if you're a CBS member. And thank you again for joining us today.